Hello, hello, hello. Welcome back, everybody. We have dared to do the impossible today. Fearlessly, we've decided to start, by we, I mean me, decided to start this meeting without the one and only Prof. Rez. Um, Worry not. I suspect he's on his way and will be here shortly, but with Prof. Rez, you never know. You got to stay on your toes. You never know what's coming your way. Um, but I'm very, very excited for today because it's a hat trick of presentations, my favorite British word. Um, but before I introduce our case presenter for today, we gotta go through our routine of emphasizing who is making this production happen. Um, First off with our scribe, our regular Friday scribe now. Zachariah, hello. Tell us a little bit about what's going on in your life since you did this about 7 days ago, I believe.
Hi everyone, I'm Zakaria from South Africa. Uh, I spent most of the week working in an emergency department and having a lot of fun seeing patients of all different sorts of pathologies and really enjoying myself. And I've probably learned more in the last month than probably my last 6 months where I was before. So having a
Incre-
great time.
Incredible. What do you feel like is the highlight? Like if you had to take us to a moment that captures just how much fun you're having, what would that moment be?
Uh, that's quite a difficult question, but I think what's highlight for me is seeing a lot of work that I've done over the last six to eight
Yeah,
years that never really seemed to pay fruit, finally coming to light and being able to benefit people with that. And I'm really enjoying that.
that sounds amazing. Yeah, no, I think it takes a long, long time for all the hard work that we do in medicine to really be apparent to you. I'm really glad you're experiencing that. Um, I'll pass the mic now to Himoon, who is making this week her VMR week, was discussing yesterday and doing teaching points today. How do you feel now after the discussion, Himoon? How does it feel post that
I
very stressful?
feel I feel much better.
Did you sleep better
Really,
last night?
yes. I was very nervous, but yeah, I feel much better now, and I'm very excited for my friend Masa's case presentation. I'm
Woohoo!
cheering for you, and yeah, I'm doing the teaching point.
Amazing.
Yeah, I'm really looking forward to it.
You are such a people person. I absolutely love it. Thank you so much, Himoon. Yeah, Masa, what's new? Give us an update before you tell us.
Hello. Thank you, Himoon. That was really nice. You're always so kind. Hey everyone, I'm Masa. I'm a medical graduate from the United Arab Emirates. And yeah, I have this case that I saw this summer in Ohio, and I'm excited to share it.
I think you said the word case and Prof. Rez popped right in. Good morning, Prof. Rez.
Good morning. I'm sorry I'm delayed, everyone. I am trying to figure out how to launch Zoom on this desktop, but I
Oh,
have it on the laptop, so we're in good shape, and I'll work on the desktop.
amazing. Do you want a minute or two to do that, or what would you prefer?
No, no, let's get going. Maybe you can tackle the first aliquot, Robbie, and I'll be listening in while I play around with this
That sounds
Zoom
great.
thing.
That sounds great. All righty,
Thank
you
you,
got
brother.
it. All right, Masa, let's rock and roll.
Okay, so I have a 77-year-old patient who presented to the emergency department with progressive yellowing of his skin and eyes for 1 week. He developed dark urine and pale stools and complained of fatigue and generalized weakness that started at the same time. He also complained of shortness of breath with minimal exertion, and this is the first time he experienced these symptoms. He denied any abdominal pain, nausea, vomiting, or diarrhea, and he denied a recent fall or injury, recent travel, and any weight loss. He was discharged from the hospital 2 weeks prior to his presentation, and at the time, he was admitted for sepsis due to osteomyelitis with an epidural abscess and received a 6-week course of antibiotics, specifically IV cefazolin. His review of systems was negative for fever, chills, sweating, chest pain, urinary symptoms, headache, and photophobia, but he did say that his eyes felt glassy. And I'll stop there.
Oh, what an intriguing start. I think that you've really given us two pieces of information to really analyze. The first is why are his eyes yellow and why is his urine dark and his pale stools? But I think the context is hard to ignore, and the context that he was recently admitted for presumably, I would say, MSSA, osteomyelitis, and epidural abscess. And the reason I would guess MSSA is because of the antibiotic treatment that was given. We've learned that when you have Staph aureus bacteremia, if you have MRSA, your hand is forced to give vancomycin, daptomycin, or linezolid. But if you have MSSA, there are actually better outcomes when you use a beta-lactam antibiotic instead of vancomycin. So the choice of cefazolin here is very, very evocative of that diagnosis. And so you could choose to begin your analysis of the background information by saying, oh, this person had MSSA, osteo, and epidural abscess. And that is the framework for which you take. But I think it's important to then uh, realize that that actually also is a consequence of something, and to wonder, where does this disease begin? Does it begin um, in relation to that hospitalization, or does it begin with an underlying diagnosis for the very reason that this person had MSSA in such a vulnerable place? And so knowing where you can start off is often a very key question, but ultimately that kind of analysis will just take you and make your wheel spin because it's hard to know where to take it. You'll be much the wiser once you know exactly what this yellowing is about and be able to draw connections related to it. And so I think whenever the eyes and the skin are yellow, we really translate that to, oh, I see Prof. Rez has you're ready, Prof. Raz. Maybe I can just actually, since I've reflected on the background, maybe I can pass the mic to you to see what you're thinking of the yellowing.
I thought you were going to say, since I've reflected on the background, let me continue my thinking so I connect the dots. you know, the yellowing, I think we can't ignore the sequence of events, but in clinical reasoning, we're always looking for our pivot point. And often it doesn't come in the HPI, meaning the HPI keeps the DDX so broad, but every now and then we do get the pivot point in the HPI, and Massa gave us the pivot point. She said yellowing of the skin and eyes. So your mind can translate that to hyperbilirubinemia. And something that Robbie once asked me, he said, how can you get yellowing of the skin but not the eye? I'll just put that out for the universe and you can put it in the chat. Or how can you get yellowing of just one eye and not the other eye? Let's put that out into the universe too. But now we have hyperbilirubinemia. And then the next step becomes, is it direct or indirect? And I will tell you, you don't even need the labs to make that determination here. You don't need the labs. If you have yellowing of the skin and dark urine, that's not enough to tell you if it's direct or indirect. Because let me give you two scenarios where you can have yellowing of the skin and dark urine, one indirect and one direct. For indirect hyperbilirubinemia, you can easily imagine hemolysis. And when you have hemolysis, that hemoglobin is going to make the urine dark, especially intravascular hemolysis. Now, if you have obstruction of the hepatobiliary system, whether it's intrahepatic or extrahepatic, you will have direct hyperbilirubinemia, and that direct bilirubin will cause the urine to be dark. So both scenarios, the urine is dark. But there's one thing that Massa mentioned here that sort of eliminates or lessens the likelihood that there's an indirect component, or if there is, it's not the major player. And that is what? The pale stools. So the pale stools, you have to then reverse synthesize, how do stools get dark in color? The way that stools get dark in color is that you need bilirubin and bile. You need bile to reach the intestines, where the bacteria then metabolize that bile, giving the stool the dark color. So the fact that the stools are pale, which is a unique finding, it tells me that something is obstructing the flow of bile from that liver to the intestines. And it can be anywhere at the liver or the biliary system. So I think this story of pale stools, dark urine, yellow skins is putting us into a hepatobiliary obstruction. And now what's interesting is that it's silent. I think that's really helpful too, because Ravi taught us the concept of silent jaundice. And silent jaundice is more common with non-obstructive hyperbilirubinemia like hemolysis. But in this case, it's pretty interesting. I'd actually love to pass the mic back to Robbie to maybe just play off that. Like, I'm trying to localize a site of pathology. And I was just curious with the background that you just discussed, if there's any way you can link that background to the foreground we're trying to analyze.
Professor, I think that it's very interesting whenever you're trying to connect jaundice to a systemic disease process, and you ask yourself, what are my two localizations for direct hyperbilirubinemia? One answer is the liver itself, and the other answer is the extrahepatic biliary tree, the plumbing. And so if you have those two things in front of you in your mind's eye, the liver itself or the plumbing, and ask yourself which one of those things has a stronger relationship with the rest of the body, and the answer is the liver. It's very, very unusual for the extrahepatic biliary tree to be in dialogue with the rest of the system. And the notable exception is when there's extrahepatic biliary disease that subsequently metastasizes to the rest of the body. And so the best example is pancreatic cancer, and then it goes everywhere, unfortunately. But the sequence of events here is inconsistent with that. So if you take it a step further and say, I have a systemic disease that began outside the liver and then went into the liver, it's very, very unusual for a systemic disease to metastasize to the extrahepatic biliary tree, though it is described. And so in all comers, whenever jaundice, direct hyperbilirubinemia develops in the context of disease elsewhere, it's much more likely to localize it in the liver, a hypervascular structure that drains the entire gastrointestinal tract rather than the extrahepatic space. And so that's probably where I would be leaning, but I think there's a counter argument to that to acknowledge that. And I think the counter argument, Prof. Rez, is that when you're trying to compare the liver and the extrahepatic biliary tree, one of them is Reza and the other is Rabi. Let me explain. The liver is so much smarter, just like that shiny, shiny head of Prof. Rez. It's brilliant. It does synthesis of proteins, it detoxifies toxins, it makes albumin. The extrahepatic biliary tree is a very simple creature that is very robotic and just does one simple thing over and over again. And it just excretes bilirubin. It's not that complicated and it's very, very mundane. And so when the liver is dysfunctional, it usually causes the patients to feel a little slow, a little confused, um, bleed a little, get infected, all sorts of things. And so here, the relative isolation of the jaundice so far is an argument for it to be localized in the extrahepatic tree. So what progress can we make, Prof. Rez? I think there's a tension. The fact that this began in the context of a systemic disease prioritizes the liver itself. But the fact that the patient seems to be recounting the story very well without an altered sensorium, without bruising, prioritizes the extrahepatic biliary tree. So, as is true in real life, I think ultimately you need to hold both hypotheses going forward. How you can connect the specific disease of MSSA bacteremia and cefazolin, I think there's probably many hypotheses, but the thing I wouldn't want to miss is a drug-induced, because drug-induced liver injury is just so common, and antibiotics are a big player in that. So I think an early hypothesis and an early action step will be, while I'm doing all this fancy workup, what do I do? Do I continue the cefazolin or do I stop it? And I would probably be talking with infectious disease about this hypothesis. I wouldn't have the skill set to know if we do stop it, what do we use? But I would probably raise that question early on so that we're not worsening the issue as the patient's getting the workup. You asked me for a brief response, and here we are 15 minutes later, Prof. Rez.
I wish it was 30 minutes later. That's so good, Robbie. Thank you.
All right, Masa, mic to you, my friend.
Okay, so for his past medical history, he has congestive heart failure, CKD that's not dialysis dependent, type 2 diabetes, hyperlipidemia, hypertension, paroxysmal AFib, Tolosa-Hunt syndrome, degenerative spondylosis, and a previous right carotid endarterectomy. His drug history is amiodarone, diclofenac, acetaminophen, polyethylene glycol, apixaban, atorvastatin, clopidogrel, dulaglutide, insulin glargine, lisinopril, and omeprazole. He's a non-smoker. He drinks alcohol occasionally, and he does not use illicit drugs. There is a history of myocardial infarction in his father, and he has no known allergies. For his physical examination, his vitals were stable. His temperature was 36.5. His heart rate was 78. Resp rate was 14. Blood pressure 117/64. And his SpO2 was 100% on room air. On general exam, he was alert and oriented, well-developed and well-nourished, with no acute distress, but he did look a little bit tired. He had generalized icterus and petechiae all over his arms, chest, and back, and he had spider angiomas on his chest and his face. His eyes had scleral icterus, and on cardio exam, there was regular rhythm, and his JVP was not raised with normal S1 and S2 sounds. His pulmonary exam was normal. There were no added lung sounds. On an abdominal exam, there was no abdominal distension or tenderness with normal bowel sounds and no organomegaly. On examination of his extremities, there was 2+ pitting edema bilaterally up to the knees. And on neurologic exam, he had decreased strength in his lower extremities compared to his upper extremities. And that's it for now.
You want me to kick it off, Prof. Red? Awesome. Yeah, you got it. So I think the exam is probably the most telling thing. What happened really with the background information is that we got a lot of things to try to connect the dots. And actually, maybe I'll leave the exam for Prof. Res because I think it's very, very juicy and probably very helpful. But I think what we learned about the patient is that they have a lot of underlying comorbidities, and the theme of their comorbidities is that they have a spectrum of metabolic dysfunction with hypertension, hyperlipidemia, and type 2 diabetes. And that seems to have had consequences on their heart with congestive heart failure as probably a consequence of that, as well as the atrial fibrillation. They've also had a carotid endarterectomy. So the underlying metabolic profile of the patient certainly changes and probably explains why, especially the diabetes, they were vulnerable to MSSA bacteremia, or I should say presumed MSSA bacteremia. But I think when you have so much dysfunction in the heart and in the kidneys, you have to wonder, as the exam, I think, emphasizes, that whether the liver is healthy to begin with. And I think with the rising incidence of metabolic dysfunction associated liver disease, when somebody has accumulated so many metabolic risk factors, I think it's very reasonable to have a pause and say, is this jaundice acute, subacute, or chronic? Or is it acute on chronic or subacute on chronic? And I think the background profile of the medication, background profile of the patient certainly opens the door to them having a spectrum of metabolic dysfunction affecting their liver. And I think the meds too are also alarming, especially amiodarone, which has a variety of hepatotoxic effects ranging from acute liver injury, often associated with IV amiodarone, which can be fulminant and just as bad as the other A, acetaminophen. And so I think that the medical history means that this is not a clean slate and that this liver may be unhealthy to begin with. And that the medications now aren't just the cefazolin, it maybe is the amiodarone as well. Prof. Raz, what do you think?
I think that's brilliant and really sets me up well to dissect the exam. And I'd like to just piggyback off of Robbie in trying to categorize or characterize this tempo. Is it acute, jaundice? Because if it's acute jaundice, you really have to be worried for life-threatening causes like acute liver failure or cholangitis. Or is this more decompensation of a chronic process? Or is it an acute on chronic process? And if you look at the exam, there's one really telling finding that there's some chronicity to this, and that's a spider angiomatas. You wouldn't expect spider angiomatas, which result from elevations in estrogen and connecting the AV arteriovenous system together to develop like that. You might expect acute portal hypertension, you might expect jaundice, but those more findings that are stigmata of cirrhosis, the caput medusae, the spider angiomatas, it really establishes some chronicity. So, Robbie, we're viewing one time point currently. And of course, we would look at the prior medical records and see, hey, was there a hyperbilirubinemia prior to all this? And also, since I think there is a component, a chronic component to this presentation, I'd be very curious to um, other labs that evaluate the function of the liver, specifically the albumin, the INR, and most importantly, the platelet. The INR, you have to be a little careful because a lot of these patients don't eat and are just feeling nauseous, and it can be elevated because of vitamin K deficiency. The albumin, you also have to be careful because a lot of these patients have chronic inflammation. Albumin is a negative acute phase reactive, so it might be low for that reason. But I think if you start synthesizing a story of thrombocytopenia, hypoalbuminemia, then you're making the case stronger. And then ultimately, imaging will give us the morphology of the liver. But I think the presence, even if the spider angiomatas weren't there, there still might be a chronic component. Because remember, the exam has more of a positive predictive value for cirrhosis rather than a negative predictive value. And there is a scenario where you can have cirrhosis and it really becomes an emergency if the patient's presenting with worsening jaundice. And it's really important to know this specific scenario because in general, when you have decompensation of a chronic process, it's okay. Like the patients, you have time. You have time to treat them. Their prognosis is much better than just a new acute injury or failure. But if someone has cirrhosis from alcohol and they suddenly present with their bilirubin shooting through the roof, now you have severe ALCAP. So it's acute decompensation of a chronic process that carries a high mortality. So that one bucket, I think, is the exception to like not being nervous for decompensation of chronic, acutely nervous. I think that there is an acute component, and we have to sort of investigate that, Robbie, whether it's the drugs, which is a high pretest, or if the infection is just not responding to antibiotics or it's back, and now you have an abscess in the hepatobiliary system that is yet obstructing the flow of bile. So really, I think the next steps are going to be labs to sort of, and imaging to sort of ask the question, is there a chronic disease, which I really think there is, of the liver? And is there an acute process like an imaging radiographic finding that may suggest an acute process? The petechiae on the back are peculiar, honestly. I can imagine them being on the extremities because people with cirrhosis, they have low thrombopoietin production, they have splenic sequestration, they're at increased risk of bleeding and at increased risk of clotting. But petechiae on the back, I would just make sure that we're not dealing with palpable, petechiae, because then all of a sudden we have to broaden the DDX to include vasculitis. So the decreased strength in the lower extremities, I'll look at the prior exam. This patient had an epidural abscess. And if it's any different, I would re-image to make sure that the abscess hasn't expanded and isn't compromising the spinal cord. I do want to just give the mic back to Robbie because I think there's a lot of information here. If he can just summarize, if you don't mind summarizing, Robbie, like where we are, because we got a lot and what we're looking forward to in the labs, I appreciate it.
Oh, for sure, Professor. I'm right there with you. I think the core problem is jaundice, and I think the time course appears to be acute on chronic. And I think the context of the patient is a prominent metabolic syndrome, a couple of drug culprits, and a recent admission for MSSA bacteremia, MSSA osteomyelitis and epidural abscess. And the accompanying features of the current clinical syndrome that may or may not be ultimate clues are the shortness of breath that he reported, along with the lower extremity predominant weakness. So, yeah, that's where I think we're trying to figure out. And I think it is going to be really interesting to see what the labs signify with regards to the liver. All right, Masa, what you got?
Okay, before I go on to the labs, I just want to clarify something. So I saw, this is my physical examination, and I saw this patient 10 weeks after he was admitted. So I just wanted to say that. Okay, so for his labs, his hemoglobin was 9.4. These are on admission. These are the labs on admission. So his hemoglobin was 9.4. His hematocrit was 29.3. MCV was 101. His white blood cells were 11.3. CRP 50.2. Sodium 135, potassium 4.1, phosphate 2.6, magnesium 2.3, BUN 69, his creatinine was 2.53, his glucose was 256, and his lactate was 7, haptoglobin was 130, AST 797, ALT 147, ALK-Phos was 489, which kept increasing and it reached 1094 after a few days. His total protein was 5.2, albumin was 3, total bilirubin 14.2, direct bilirubin 9, his INR was 2.2, his ProTime was 24.7. And his TSH was 0.373, free T4 0.8, and his CK was 45. I have some expanded chemistry, but I think I'm gonna stop here.
All right, thank you, Masa. I think what I'll do is just quickly tackle the CBC and leave the rest for Robbie to dissect. When you're dealing with liver disease and abnormal CBC, this is really the expected pattern. I'm waiting for them. Do you have the platelet count, Masa? I'm sorry, I don't see it there.
I actually don't.
Oh, you
I'm
don't? No
sorry.
worries at all. That's okay. Uh, no, don't apologize. I think that we know the MCV being elevated is consistent with someone having liver disease, and the hemoglobin being 9.4 is probably a consequence of chronic inflammation, though we can exclude portal hypertension causing splenic sequestration and also leading to a thrombocytopenia. That's all I have to say about the CBC. It's sort of in line with what I expected. Of course, I would look at the prior hemoglobin, and I would say that when I'm interpreting the haptoglobin, I'll just be cautious. I think, Roy, one of our theories was, is this hemolysis or not? And knowing that you can have, though haptoglobin is probably the most specific marker and sensitive marker of hemolysis, you can have low levels with chronic liver disease. So don't get fooled by that.
I love it. I completely agree. I mean, I just wanted to clarify one thing, Masa. Is the lactate a high or was that 7 or 0.7? I wasn't expecting it to be high based on what you had presented. So but before incorporating
It's
into
7.
I said, oh, okay, all right, gotcha. That's very helpful. Yeah, so I think the first thing that would probably grab your attention if you were taking care of this patient in real life is to see, well, whoa, why is their lactate so high? And I think that your the first branch point for lactate is to recognize that it is a consequence of anaerobic metabolism. And the first question that you're trying to figure out in a patient who has anaerobic metabolism is to say, is it a perfusion issue? And is there something that are the tissues hypoxic and therefore undergoing anaerobic metabolism? And with the blood pressure that he has and the lack of evidence to suggest that, I think you would probably say probably not and move over to other forms of anaerobic metabolism, which are really microscopic dysfunction of the mitochondria. And that the microscopic dysfunction of the mitochondria can be a genetic disease, but that really serves as a reminder for what else can happen to mitochondria in adults. And one of the things we see very frequently is toxins and nutritional issues. So toxins would include alcohol, and nutritional issues would include thiamine deficiency, but also medications. And the list of medications is very long, includes metformin, includes propofol, includes linezolid. And I don't see any offending medications on his list. Um, so then would wonder, okay, is this just a marker of his liver not being able to clear lactate? And I think that's a hypothesis to hold on to. That's because the liver's not in great shape. And I think with a bilirubin of 14 and INR of 2.2, you have to worry about this liver. And I think to answer deliberately the question of what is the time course of this disease and what is the localization? Is it in the liver or is it in the biliary tree? I think the degree of AST and ALT elevation suggests a big component of this disease is in the liver itself. That's because, again, the biliary system is not very smart. It doesn't have much AST or ALT to give. And so I think the predominant localization here is probably in the liver itself. And so the time course, we see spider angiomas. We see evidence of chronic liver disease. We see a risk profile for chronic liver disease on the patient's medical history. But there's a big counter argument to this being just chronic alone, and that's the height of the liver enzymes. When you have chronic liver dysfunction, no different than chronic kidney dysfunction, it's very, very hard for your enzymes to be over 200 or 300. And so the fact that he's able to release this many liver enzymes into his blood system means that he has enough hepatocytes to do so, which means that he's probably not having decompensated cirrhosis alone. And I think, what would help you is, of course, to see if there's evidence of portal hypertension on exam, which we didn't see evidence of, um, that I don't remember actually, to be honest. But I think that's where a point of care ultrasound or a formal ultrasound to look for ascites would be very, very helpful. So I'm worried more and more this is actually not a decompensated cirrhosis, but rather a disease that is active and ongoing and causing liver dysfunction. And so would probably just engage in the tried and trusted workup for acute liver dysfunction, which is infection, infection, infection. Hepatitis viruses are the most common, but there are other ones. And then drugs, drugs, drugs. And we've already talked about the drug category. But let's not ignore the clue on the table. There are two clues. The first is that the AST is much higher than the ALT. And whenever you have an AST much higher than ALT, you have to think, wait, is this actually the liver or is it something else? And the only thing else that can cause an AST this high outside the liver is the muscle. And that's great to see the CK normal, although I don't think you would suspect a CK being the cause because the AST is higher than the ALT, but there's also overt liver dysfunction with the bilirubin. And so you're like, well, what else causes an AST higher than ALT except alcohol? And that's when your trusted friend amiodarone comes in. Amiodarone-induced liver disease notoriously causes an AST predominant elevation. Actually, I learned this from Ravi. We've brought him up twice already, Prof. Rez. He presented a case of amiodarone-induced hepatic dysfunction, where I learned this really cool pearl from. The other clue on the table here is the fact that the alk phos is rising so much. Why is the alk phos rising? Well, it could be because there's extrahepatic biliary disease, but it also could be because there is microscopic dysfunction of the small bile canaliculi in the liver itself. So as we try to localize the disease in the liver, is it a disease of the hepatocytes, like acute viral hepatitis? Is it a disease of the intrahepatic bile duct cells, like primary biliary cholangitis? Or is it a disease that infiltrates between those two cells, causing hepatocellular dysfunction and biliary dysfunction? And that is essentially a classic example of what is an infiltrative disease. And what's really interesting about amiodarone is it causes steatohepatitis and buildup of fat in the liver. And so just like alcohol. And so a part of me is wondering, is this the effect of amiodarone-induced steatohepatitis? But I think what we're really seeing here is a mixed picture of hepatocellular injury and cholestatic injury. And not just amio, but that is a very suggestive feature of drug-induced liver injury. So I would really be sending off viral hepatitis markers. And I would be really worried about the amiodarone and the cefazolin right now, and would probably reach out to the respective colleagues, cardiology and hepatology and ID, to see how we can navigate them going forward. And I think ultrasound will be helpful to make sure that this is a massless liver disease, but also to make sure that our localization is not wrong and that this is not something that involves the extrahepatic biliary tree. So I said a lot, but I'll summarize the key things. The height of the liver enzyme elevation suggests an acute component here. I think the clues to the disease process are the base rate, infection, and drugs. The specific clues in this case are the AST predominance and the mixed hepatocellular and cholestatic pattern. And I would be using those clues to really help move the case forward. Prof. Rez, I'm curious if your mind latched on to any other things that you picked up, because this is a little bit of a interesting pattern we're dealing with.
Honestly, no. I think you really summarized it really, really well. Very curious to the imaging, so then we can go down that pathway. And also interesting in repeat LFTs, Robbie, because like many of the causes, if it's ischemia, if it's a stone that passed, you'll see a downtrend with no intervention. But if it's a drug culprit, usually it stays persistent, especially something like amiodarone that stays in the system for weeks before it's completely depleted.
Okay, Prof. Rez, I got the platelets. It's 57K.
Thank you.
I did a little search. Anyway, so the next set of labs, his acetaminophen level was negative, his ethanol negative, salicylate is negative. His hepatitis panel was negative, CMV, EBV, HSV, and HIV were all negative. Anti-MPO, ANA, P-ANCA, mitochondrial antibody, and smooth muscle antibody were all negative. And his chest X-ray showed congested hilar vascular markings. And on ultrasound of the right upper quadrant, there was hepatomegaly with diffusely increased echogenicity. His gallbladder was contracted. There were no calculi or sludge and no obstructive lesion in the biliary tree. I'm going to reveal the diagnosis next.
And Masa, just to confirm, no ascites, right? On the abdominal ultrasound? Not a drop of fluid. Okay, all right. Thank you, Masa. That's very helpful.
The report said.
You're like, no, that's not what the report says. I love it. Yeah, I'm glad there isn't a prominent amount of ascites. I know you probably can't commit to not a single drop. I understand. Um, yeah, I think as Prof has just put in the chat, I think it's amazing how much you forget the no misses, and I really appreciate you, Masa, reminding us of just how key the Tylenol level is here. I think that you also taught us that in addition to sending hepatitis as causes of infectious liver disease, in an unusual case like this, you're extending your infectious workup to what Harry Hollander famously teaches are the moonlighters of liver infections, which are the herpes viruses. So testing for those, I think, is very wise. I've been fooled, but Prof. Rez hasn't. He rescued us once in a live clinical reasoning session where the diagnosis was CMV hepatitis. I
You know
remember.
why, right? Because I'm the smart liver. You're the dumb
Yeah,
billion guy.
exactly. Exactly. We were in Georgetown and I was like fumbling, and Prof. Rez was like, "This is CMV from the prior blood transfusion." And you can tell I will. This is like 5 years ago, but I'll never forget it. So I really, really appreciate you making that point today, Masa, that like we should think of those things. And you actually took your work up a layer beyond. You took that layer beyond and looked for autoimmune diseases, which I think are very wise, of how unusual this data is. And so it sounds like the next aliquot will reveal the diagnosis. So I think we're going to have to lean heavily on Prof. Rez's analysis of the imaging to to tell us what's going on.
Yeah, thank you, Robbie. Your memory is so good. I do remember that day where for 1 out of 1 million, I got this. I got the DXE for you. You let me have it, man. I appreciate it. But Massa, I think what you're telling us is like Robbie predicted in that this is really image negative, severe acute liver injury. And I say severe acute liver injury based on the height of the AST and ALT, but it's not liver failure because there's no encephalopathy. And I bet you that, and we know that there's a chronic component to all this. So, Robbie, where I am is exactly where you were. I think the drugs are the most likely culprit to cause an image negative mixed pattern of severe liver injury. And then the question becomes which one is the most likely culprit? And we know antibiotics can do it, and we know amiodarone can do it. And I wonder too if a liver that's diseased because of metabolic associated liver dysfunction is more vulnerable to drug injury compared like a brain with dementia that's more vulnerable to altered mental status. So I think there's a formula. I'm forgetting to tell you the risk of like prognosis. I think it's Hyde's or I don't even know what it is. It's probably not important. Very much like the R factor is not that important. Like no, people don't really use the R factor, even though we're taught it. And it's like theoretically it's exciting, but in reality it just comes down to looking in the height of the various elevation and enzymes. The thing here is that you don't want to just you really have to worry like, is this patient going to continue to have progressive liver dysfunction and need a liver transplant? Or is this process going to reverse itself? I, not speaking to the specialist, would like hold on the amio, but knowing that the amio is not going to leave the system for, for several weeks, I would hold the antibiotic, involve the specialist. And honestly, just so I don't miss anything, I would wonder if a liver biopsy is indicated. And I would love your thoughts on that, Robbie, because I'm not exactly sure how that, what you think the specialist would say to something like that.
First, I completely agree with your analysis. I think just to get it out as a low low probability but high consequence hypothesis is whenever you have hepatomegaly and infiltration and congestion on your chest, you have to wonder for a second, is this decompensated heart failure? And I've been fooled by that so many times. So I would just say like make sure you get a BNP in this patient, but and because I'm just looking, I saw in the exam he has 2+ pitting edema. So I think the probability of that is pretty low when the liver is so disproportionately affected. And you often see like kidney injury, the patient gets hypotensive, but I think, we've been burned by that before. So I think that's an hypothesis that you can verify with a simple blood test, a point of care ultrasound to look for the IVC. But I don't think that's probable. I think what Prof. Rez is saying is a very elegant way of working this up. You would probably stop all culprit medications, and you would wait to see if the patient improves or not. If they don't improve, I think you need a liver biopsy for sure. I'm gonna use the fact that Masa told us that she saw the patient on week 10 of the hospitalization to say that you can anticipate that this is a prolonged, protracted course. I will take advantage of the fact that the liver is big. I think it's unusual for the liver to be big uh, in cases like this. So I think it just reinforces the notion that unless it's big from passive congestion from the heart, it's big because there's something infiltrating it, though rarely it can be big because it is edematous from hepatitis. And so I think that's where the yield of the liver biopsy may be even higher when you are invoking the idea that there was something infiltrative. So yeah, I'm right there with you, Prof. Rez. I would say hold all culprit medications and trend the liver enzymes, as you said. And if there's no improvement, I think a liver biopsy can be very, very, very illuminating. What did you do, Masa?
Okay, so this patient's amiodarone was switched to diltiazem, and then his atorvastatin was stopped, and his cefazolin was switched to daptomycin, and his liver functions started to trend downwards like significantly, and he ended up with an AST of 142 and an ALT of 362, and was diagnosed with drug-induced liver injury. He was referred to the hepatologist, but I did not see him after that. So unfortunately, I don't know what happened. But yeah, I don't know. I guess this is just like one of those cases. Like fun fact, drug-induced liver injury occurs in 10 to 15% of patients, which like I don't think that's a number to sleep on, I think. And so I don't know, it just like taught me the importance of reviewing the patient medications and making sure there are no harmful drug interactions. And then I also included thyroid function test because I also learned that hyperthyroidism can cause indirect hyperbilirubinemia by increased red blood cell turnover, which causes hemolysis, and then also altered conjugation. And so I just thought like that's something to look out for as well. Um, and he has a history of Tolosa-Hunt syndrome, which that was the first time I ever heard of that. And it's actually so rare. It happens in 1 million people, and it is an a painful ophthalmoplegia because of granulomatous inflammation of the cavernous sinus. And it occurs due to viral diseases or any systemic infection that can trigger an inflammatory response. Um, and then a small like patient care thing that like stuck with me, and it's like really, really minor, but it just stuck with me. Every time the attending and I would go and see this patient, he would complain of how tired he was. And then one day he just went, I have nothing new to tell you. And then the attending was like, this is the first time you don't complain of how tired you are. And I just thought like it just goes to show how important it is to pay attention to like these little details. And yeah, that's all I have to share. And thank you everyone for listening. And thank you, Dr. Rabi and Prof. Rez, for this amazing discussion.
I just love that. I think that's such a wonderful reflection. You taught us so much about drug-induced liver injury, about Tolosa Hunt. You couldn't help it. The CP solvers in you has to get nerdy, and then just the attention to detail about what matters most to the patient. And I think you are probably obsessing about the INR, but the patient doesn't even know what that is, likely, right? And so I think hearing them and making sure that you hear them out at least, and you may not be able to do much about the fatigue, but I think if you don't acknowledge it and feel it like the patient does, you're not helping your patient. I absolutely love this case. There's a lot of, really fundamental bread and butter questions related to liver disease. How do you localize jaundice to the liver versus indirect? How do you know where the disease is once you've localized it to direct in the liver or the extrahepatic tree? What is the time course? What are the most common causes? And how do you find um, an answer when you can't prove it? And I think you're learning that with drug-induced liver injury. As Prof. Rez expected and hoped, I think the diagnosis is really clinched by stopping the meds and seeing how the patient gets better, or hopefully the patient gets better. Prof. Rez, thoughts, reflections?
Yeah, I too want to thank you, Masa. It was an incredible case. And I think it's really these cases that help us grow and taking care of the bread and butter. So I really appreciate it. And Robbie, I think like I'm just going back to the silent jaundice. Like usually we prioritize hemolysis, but if you were to prioritize one cause of hepatobiliary silent jaundice, I think it would be drug-induced liver injury. I'm just thinking back in my 10 years of medicine. That's the only time I've seen someone have no abdominal pain, have this degree of hyperbilirubinemia, because all the other causes, like the viruses, the masses, the infections, etc., they usually come with like a strong inflammatory or pain component to it. I'll be thinking about that more, like what else can cause silent jaundice that's hepatobiliary. Guys, I want to apologize. I have to go. I would love to hang out longer, but I gotta go round. But thank you
Hey,
so
wait,
much for
wait
this
for my
hour.
joke. Wait for my joke. My joke is that
Okay.
jaundice can be silent, but nothing can silence you, Prof. Rez. Thank you for your outstanding contribution.
I love you, man. Thank you so much.
Happy rounding. All right, Masa. Thank you again. That was a real, real treat. We'll pass the mic to Himun to take us through the teaching points.
Yes, Masa, this was amazing case and very, very interesting case. So the patient, 77 years old, male with a yellow eye and pale stool with post MSA and when Rabih mentioned about cefazolin, there was something he said he was not using vancomycin or daptomycin, so that was kind of interesting. And the patient was with hyperbilirubinemia in dark skin patient with a dark urine, so we thought that it could be both like indirect and direct, but the pale stir indicate to direct bilirubin because of a lack of bile in intestine. And also we talk about intrahepatic and extrahepatic bilirubin, and those lab exam really indicate liver disease. But Rabih mentioned that the liver performs vital function like metabolism, detoxification, coagulation, albumin control. So isolate jaundice is not solely indicative of liver dysfunctions. And liver with a high metabolic risk factor and jaundice and the person was having amiodarone could be very hepatotoxic, and we thought we should look at tempo, whether it's acute or chronic, and acute like liver failure or cholangitis, and chronic cirrhosis like spider angina indicate elevated estrogen. So we should look for anemia, INR, or albumin change, or hyperbilirubinemia. So next step was imaging for acute process and the study for like petechiae, whether it's because of the due to the cirrhosis, the thrombocytopenia, and also mitochondrial toxicity due to alcohol or like a drug like a linezolid or other drug was mentioned. And also we thought about elevate significant AST/ALT level is acute, and we should study for hepatitis drug and look for sono for looking for the ascites, but there was no ascites. And AST was significantly elevated compared to ALT, so CK could be another great tool to look for it. And also alcohol and amiodarone could cause that too. So mentioned that we could do the liver function test one more time. And the imaging reveals hepatomegaly, so strongly indicating it's due to hepatitis or maybe something environment with the heart or kidney. And the progressive liver dysfunction was, we have to think about whether it's reversible or not. So holding the old antibiotic and involved with a specialist, and Massa finally indicate that it was due to drug-induced liver injury from amiodarone and cefazolin, which is cefazolin. Thank you so much.
I hereby propose that this week be called Moon Week on VMR after an incredible case discussion yesterday, clinching the diagnosis with her last words, following it up with an absolutely outstanding teaching today. You literally caught everything and summarized it so well. I really, really appreciate it. What a wonderful day. Thank you so much, Masa, for an awesome case. Zakaria for ferociously keeping up with the, especially the medical history. I was like, wow, he's actually keeping in tune with the sheer volume of this information. And of course, last but not least, Moon. All right, guys, have a great rest of your day, and hope to see you next time. Bye.